Dear Chair, dear audience, it's a pleasure to share the progress of my PhD studies, where I'm investigating the effectiveness of arterial and venous endovascular procedures. My name is Dávid Laczkó. I'm a second-year PhD student and a radiology resident at the Department of Interventional Radiology at Semmelweis University, and my vision is to eliminate the consequences of vascular diseases by making endovascular procedures more available and widespread, and to provide clinicians with an up-to-date knowledge to help them choose the most appropriate interventions. In order to achieve this, we started two projects. In the first one, we are investigating the effectiveness and safety of embolic agents in bronchial artery embolization. We know that severe and recurrent hemoptysis is a life-threatening emergency with a mortality rate of up to 70 to 80%. We also know that 90% of these cases are caused by the bronchial circulation due to either inflammatory or malignant lung diseases. Possible treatments include conservative treatment, which lacks long-term effectiveness, surgical treatment, which can be associated with a high perioperative mortality, and last but not least, the gold standard, the endovascular treatment. Now, the endovascular treatment can be achieved by three main types of embolic agents. First, there are the particle agents, including polyvinyl alcohol and microsphere. Second, the liquid agent, including N-butylcyanide. And last, we have coils, but the current practice is to only use them together with the previous two agents. So we know that we have a few options, but currently there's no consensus on a gold standard agent. Therefore, in our study, we investigated patients presenting with hemoptysis treated with either particle or liquid embolic agents, and our main outcome was the 1-year hemoptysis recurrence rate. Secondary outcomes included technical and clinical success, mortality, and complication rates. And we hypothesized that the particle and liquid embolizing agents are both effective and safe in the bronchial artery embolization. Here you can see our search key. We have two domains. The first domain refers to the procedure, and the second domain refers to the hemoptysis. With this search key, we managed to find over 5,500 articles, and in the end, we managed to extract data from 59 articles. The first result I would like to present is the clinical success. Now, clinical success is defined as the complete cessation or at least a 50% reduction in hemoptysis volume after the embolization in the first 24 hours. Here you can see the outcomes in the liquid papers. I would like to emphasize that all of these papers were retrospective observational studies, and the results are expressed in proportions ranging from 0 to 1, 0 meaning none of the patients had a clinically successful procedure, 1 meaning that all of them had a successful procedure. You can see that the pooled effect size is 0.95, meaning that out of 100 patients, 95 patients had a clinically successful procedure. Here you can see the outcomes for the studies investigating the particle agents. Again, all of these studies were retrospective observational studies, and the pooled effect size was 0.95 here as well. I would like to highlight that we have a few studies that were outliers, and after investigating these studies further, we realized that they investigated patients with lung cancer. All in all, we can say that there was neither clinical nor statistical difference between the two agents. The other outcome I like to present is the 12-month recurrence rate. This is an important outcome as this reflects the long-term effectiveness of an embolizing agent. Here you can see the results of the liquid papers. Again, all of these were retrospective observational studies. Outcomes are expressed in proportions ranging from 0 to 1, this time 0 meaning that none of the patients experienced recurrence, and 1 meaning that all of the patients experienced recurrence. Here you can see that in the liquid group, the pooled effect measure was 0.14, and again, we could see an outlier study, which again was a study that investigated exclusively lung cancer patients. Here you can see the 12-month recurrence rates in the particle agent studies, and the pooled effect size was 0.17. And again, we could see some outliers, and we also realized that these articles were investigating lung cancer patients. We could see that between these two agents, there was neither clinical nor statistical difference in the 12-month recurrence rate. After seeing all of these outlying studies, we conducted a subgroup analysis investigating the malignant and non-malignant patients, and we could see that in the clinical success, the pooled effect was 0.74 for for the malignant patients and 0.97 for the non-malignant patients, which this time was both a clinically and a statistically significant difference. After investigating the 12-month recurrence rates in these two subgroups, we could see that the recurrence rate was 0.66 for the malignant patients and 0.11 for the non-malignant patients, which again was both a clinically and a statistically significant difference. To better visualize these results, here you can see the recurrence rate at different follow-up times for the two subgroups, and you can see that at 12 months there was a significant difference between these subgroups. Of course, our studies had strengths and limitations. We included a large number of studies, and we have a definitive answer to our clinical question. However, we were limited by the fact that only retrospective observational studies were reported, and the populations were quite heterogeneous. So all in all, we can conclude that both of these agents are effective and safe in the bronchial artery embolization, and there seems to be no risk associated with using either of these agents. Therefore, we can advise investigators to freely study these agents in a randomized controlled trial. We submitted this paper to radiology, where we received a major revision that we plan on addressing in the following days and send it back for further revision. In the following few minutes, I would like to introduce my second project as well, where we are comparing the effectiveness and safety of single and dual antiplatelet therapy in patients with intermittent claudication. Peripheral artery disease is a very common disease affecting over 100 million people globally and making a major contribution to the number of major amputations annually and global healthcare expenditure. We also know that this is a progressive disease where the different stages are described by the Fontaine classification. Patients in the later stages experiencing rest pain and ulcers have a 20-year, 1-year mortality, and 30% of patients in earlier stages, namely the patients with intermittent claudication, progress into the later stages at one point of their disease. Therefore, it is crucial to have an effective treatment and prevention in patients with intermittent claudication, which the effective treatment consists of endovascular angioplasty with or without stent placement, and the prevention is the antiplatelet therapy. However, we have a gap in our knowledge here. We know that a lifelong antiplatelet therapy is always indicated in this patient population. However, we don't know if a dual antiplatelet therapy is indicated, and if it is indicated, for how long should these patients be given these medications. In the literature, there haven't been any RCT studies to compare these two therapies, so our aim is to conduct an RCT to compare the effectiveness and safety of the single and dual antiplatelet therapy. In our study, we would investigate patients presenting with intermittent claudication undergoing endovascular treatment, either receiving dual antiplatelet therapy or single antiplatelet therapy. And our outcome would be clinical progression, and our hypothesis is that the dual antiplatelet therapy reduces the post-procedure rate of clinical progression in patients with intermittent claudication. And the clinical implication would be to introducing an evidence-based standard of care in this patient population. This is the first draft of this RCT, so it's very rudimentary, but we would exclude patients that require dual antiplatelet therapy or patients that would require any kind of anticoagulant treatment. And one of the study would receive aspirin combined with clopidogrel, and the other one would receive aspirin plus placebo for 12 months. The primary outcome would be measured as a change in pain-free walking distance at different follow-up times, or as the stenosis progression rate measured by ultrasound at these follow-up times. To summarize, we have two studies that we are conducting. The first one will hopefully be published soon, and the second one we shall start drafting the protocol and move on with the sample size calculation as well. To summarize my additional activities, I had the privilege of joining the center as a scientific methodology supervisor, where currently I'm overseeing the work of 11 first-year PhD students, and along with that, I had the chance to present my scientific findings at numerous national and international conferences as well. I would like to end my presentation with one of my favorite quotes by W.C. Fields: "If at first you don't succeed, try again." Thank you for your attention.
I want to ask for, regarding to your first project, you say 3 embolic agents are used, the particle, the liquid and the coil.
Yes.
And if I remember well, you say you don't use the coil agent, and why? Because it's expensive, ineffective, or cause many adverse events. So.
Yeah, I mean, it's not completely true that we don't use it. We just don't use it as a sole embolizing agent. The problem with the coils are that they cause a very proximal embolization. And if you don't embolize the target vessels or the culprit vessels that cause the bleeding, that might result in there being new collaterals. And these new collaterals are very hard to actually insert the wire into, and therefore it's very hard to embolize. So it can, in the case of recurrent hemoptysis, it can prevent further interventions. So that's why it's not used as a sole agent.
You said you investigate liquid and particle, and you are using both, but which one are you using more and why? Or how do you choose which one?
That's a very good question. So in our practice, we use the particle agent, mainly polyvinyl alcohol. Now, I think this is something that I did not have time to discuss during the introduction, but the liquid agent is used in combination with a substance called lipiodol. So basically what would happen if we only use the liquid agent, which is actually just a very simple glue, is that the moment it comes into contact with the blood, the polymerization happens instantly. So that would mean that the glue would get stuck to the tip of the catheter, which is a very expensive thing, and so that would increase the cost of the interventions. So we dilute this liquid agent with lipiodol, and by choosing different dilution ratios, we can influence the polymerization rate. But here's the thing, if we use too much lipiodol and we dilute it too much, then what we can see is that the embolizing agent passes through the target vessel and it goes outside of the screen, and we have no idea where it will end up. It can end up in the brain, it can end up in the lower limbs, it can end up in the mesenteric arteries, and they can then cause some very serious complications. So of course you have to have a lot of experience with these liquid agents to know what kind of dilution rate to use. So, and in our center, I think people, I wouldn't say they don't have this experience, but they like using the PV agent because of these reasons.
Please let me congratulate for your presentation. I have a question regarding your first project. For embolization of bleedings, they also use coils or microcoils for the embolization. Why did you decide not to include coils in your meta-analysis?
Basically, just as I answered to Anna's question, current guidelines don't recommend using it as a sole agent. We had articles where they use coils, but they weren't used to actually embolize the target vessel, but rather they were used to embolize maybe the spinal arteries to prevent complications. And another place where they use this agent is if there's like a bronchopulmonary AV fistule, which the primary agent for those conditions are the coils rather than the liquid or the liquid agent.
You said the rate of reoccurrence is in malignant hemoptysis 60%,
yes.
And in the others roughly 11.
Yes, roughly.
I guess it's probably much higher because in the malignant group, I think people die out. So you are going to lose the ones who have you seen the groups? In the reoccurrence groups, there are probably less people still living.
Yeah, but basically that's very true. We have many additional forest plots. One of them is about the all-cause mortality, and of course we can see a significant difference between the lung cancer patients and the non-lung cancer patients. So that's true that patients are more likely to die earlier. But I think the way that these these articles reported the recurrence with event numbers. So we know for a fact that how many patients experienced the recurrence, regardless whether they died early or not.
Can you go back to the slide when we see the recurrence rates at different follow-up times?
Yes, 1 second.
Okay. So my question is, when you checked the studies underlying this data, do they mention something about censoring or survival estimate, Kaplan-Meier curve? Because it seems to me it's time to event data.
Mm-hmm.
Did you see in the publication?
Yes, there were. I mean, it was kind of mixed. There were some publications where they had the Kaplan-Meier curves with the, the number at risk patients and the total number of patients at like 1, 3, and 6 and 12 months. But other times they just reported the number of patients that experienced the recurrence rates at the follow-up times without having a Kaplan-Meier curve.
So maybe it's or not accepted yet, am I right?
It's under major revision.
Major, okay, so it will be, so hopefully.
Hopefully. We are
so
hoping for the best.
I just mentioned for everybody that it's possible to analyze directly also time to event data. So we can digitalize with WebPlot Digitizer the KM curves and we can analyze them together. So thank you, and maybe just a small question. What is censoring? So what is why we need time to event here? So can you share with the audience what is censoring? Why it happens? What is it?
To my understanding, censoring in like time to event data is that if, for example, a patient is lost to follow-up or they don't have enough available data about the progression of the disease, then we use censoring to adjust for these missing data.
And basically, you are right. You said it quite well. This is censoring, and time to event analysis, survival analysis takes into account also censoring. So a bit more accurate, I can say. But thank you, and congratulations again.
I just am a little bit curious about in Hungary for cancer patients. Is this embolizing is available for which stadium? Is it an elective procedure or an emergency procedure? Can even work, or is there any data, or what's the clinical aspect?
Yeah, thank you for the question. I think it's available for lung cancer patients. I know for a fact because at Városmajor I've seen these procedures, and of course it's available for both elective patients, and I think we have this so-called bleeding clinic at Városmajor, where the emergency bleedings are embolized, including hemoptysis and of course lung cancer patients as well if needed.
And do you have any data on the success rate?
We have a database, but we haven't really analyzed it yet, but maybe as a future project we can do it.